we have, in the midbrain, we have these circuits. The key nucleus for horizontal conjugate eye movements is the abducens nucleus, the sixth nerve nucleus. For horizontal, medial rectus in the ocular motor nucleus. To move the eyes to the left, for example, we need to innervate the left lateral rectus and the right medial rectus. The abducens nucleus sends its axons to the lateral rectus from the lateral rectus motor neurons, abducens nerve. And to innervate the ocular motor nucleus, we have another class of neurons in the pons, the abducens internuclear neurons, and they project to the ocular motor nucleus. Key point, the abducens nucleus contains motor neurons and interneurons. They carry all the conjugate eye movement commands, saccade, pursuit, and vestibular. Here's our MLF, our medial longitudinal fasciculus, carries its commands to the medial rectus motor neurons, which in turn go to the medial rectus muscle via the ocular motor nerve. Vergence has its own special pathway. It has its own back door to the medial rectus motor neurons. Now, that was the basic horizontal conjugate pathway. Saccades use the same pathway. The commands come from the paramedian pontine reticular formation, the PPRF, which is located there in the pons. And the pons receives its commands from the cortex via the superior colliculus, and then it projects also to the abducens nucleus. All right, let's see a case. Here's an elderly woman with the sudden onset of double vision and dizziness. She's looking to the right, trying to look to the right. Only the left eye goes to the right. Left. Look at convergence. So, an elderly woman with sudden onset of double vision and dizziness, she can look to the right conjugately only with her left eye, but she can look to the right with her left eye using convergence. What are the findings? Abduction weakness, adduction weakness overcome by convergence, abduction nystagmus. This, of course, we know is the classical lesion in the medial longitudinal fasciculus. There it is. There's the pons, the white part above the arrow. Above the arrow is the bottom of the fourth ventricle. The vertical part is where the MLF, the medial longitudinal fasciculus, is. And this, of course, is internuclear ophthalmoplegia. Textbook case. We're going to come back to some of the subtleties of this syndrome a little later today. So, where's the lesion? Smack in the MLF. Vergence was spared because it has direct access to the medial rectus motor neurons. It does not need the MLF. All horizontal conjugate movements were affected. Vergence was spared. Now let's see a few subtle cases of this for the experts. I'm going to show you another patient with slowing of adduction. With mild lesions, you need not see limitation of medial rectus function, but you may only see slowing. And you may, of course, note that these patients also have nystagmus in the abducting eye. So here's our patient. Looking to the right is fine. Looking to the left, there's slowing of adduction and abducting nystagmus. So you may only see this if you ask the patient to make saccades, or if you have an OKN tape. Slowing of adduction and abducting nystagmus. This is a patient with multiple sclerosis. Let's look at a close-up. Abduction is fast, adduction is slowing. The classical findings, a subtle slowing of the adducting eye and a rather fast abduction. Clinical pearls. Clinical pearls. With demyelinating diseases, saccades may be slow, but the range of motion can be relatively preserved. In other words, this is a mismatch between the velocity command, which requires high frequency discharge, which is impaired on demyelinated fibers, and sparing of the position command, which only requires low frequency firing. So this is a velocity position mismatch that you see with demyelination. This is the opposite of myasthenia gravis. You can see a pseudo-INO in myasthenia gravis, but typically the range is limited, but saccades are fast. With demyelinating disease, the range can be full, but saccades are slow, just the opposite. Here's a patient, two patients with ocular myasthenia gravis. Now this patient, you can see the eye starts out fast, but then it kind of slows down. So with myasthenia, it starts fast, it may quiver a little bit, and then it slows down, but the range is limited. Here's another patient with a pseudo-INO with myasthenia. It can look very similar to demyelinating disease, but careful analysis can often reveal the difference. Pseudo-INO with slow adduction and myasthenia gravis, with quiver eye movements. Start fast, they stop, and then they drift in myasthenia. Okay, another case. Excuse me, I take a little drink of coffee. That's kind of nice on when you can lecture from afar. So is there anything wrong here? This is a young woman in her 30s with headaches, dizziness, nausea, lethargy, and supposedly a normal neurological exam by neurosurgery. We just don't know for sure, of course. I like neurosurgeons, they're very important, but occasionally they don't pay such close attention to saccade speed, for example. Well, is there anything wrong here? If you look at this MRI scan, yes, and the patient had a lesion in the fourth ventricle. You can see that on the left, smack in the center, and you can see it on the sagittal section on the right. And this patient at surgery had a pilocytic astrocytoma. Pilocytic astrocytoma. Now here's the examination, which we were able to do right after the surgery, and let's see how this works. Patient was from India. Asked to look to the right, she couldn't do it. She could not look to the left. Looking straight ahead was okay, but she could converge. Both eyes could adduct with convergence. So no conjugate movement to her left, but she had vergent movements. So here's a doll's head maneuver. There is no vestibular response in the horizontal plane. She could look up with saccades. She could look down with saccades. She had some partial preservation of the vertical vestibular response, not completely. So that's our clinical story. I'm going to give you a few exam questions. You can keep track of how well you do at home. This patient shows a bilateral facial nerve palsy. I didn't mention it, but her face was very flat. And which of the following, A, B, C, or D? Did she, all eye movements paralyzed? Did she have a horizontal and vertical gaze palsy? Was there a complete horizontal conjugate gaze palsy? Or did she have spared horizontal gaze palsy with spared horizontal vestibular. So I don't think you need to look this up. This obviously is a complete horizontal conjugate gaze palsy. Vertical was okay in terms of range. She did not have spared horizontal vestibular. This is what we saw. She couldn't look right. She couldn't look left. She could look up. She could look near. She could look down. All right, here's post-operative imaging. Is there anything wrong here? Anything wrong here? Is there a lesion that might be related to her eye movement exam? Is there anything missing? What did my friendly neurosurgeon take out that he probably wished he had not taken out? This is a T2 image. Remember, CSF is white. Here's her pre-imaging. Here's her post-imaging. That's what's missing. A little divot of the dorsal pons, unfortunately, was removed at the time the tumor was removed. So, with this missing dorsal pons, does that explain her findings? Absolutely. Absolutely. She had a lesion involving areas including facial nerve, where it crosses over, and the abducens nuclei on both sides, and probably involving the MLF as well. So this is a, if you will, a classical lesion of the dorsal pons involving the horizontal conjugate gaze palsy. The facial nerve, the abducens nucleus, and the MLF. There's her lesion, the bottom of the arrow. That's our pathway. All conjugate movements, saccades, vestibular, pursuit horizontally. Vergence was spared. In terms of the vertical, excuse me, in terms of the vertical system, we didn't go into detail, but gaze holding, pursuit, and vestibular were all moderately affected, but saccades were clearly spared. She had nice, rapid saccades. So what are the key points of this case? Abducens nucleus contains neurons for all ipsilateral conjugate commands: saccades, pursuit, vestibular, gaze holding. Vergence has a separate pathway in the midbrain to produce adduction. Vertical saccades are spared, but vertical vestibular, pursuit, and gaze holding may be impaired with bilateral MLF. The seventh nerve genu is commonly involved by abducens nucleus lesions. All right, let's give you another case. This is a woman with a slowly progressive ataxia, trying to look left and right. You want to ask yourself, are the saccades normal speed? Are they accurate? Are they promptly generated? Well, look what happens. She gets the eye all the way there. It stays there, but it is. Now look at obliquely when she tries up left and down right. The eye doesn't go straight from one place to another. It has an L-shaped trajectory. So this is it is again. So what does she show? Abnormal pursuit? Well, I didn't show it to you. I'm going to tell you it's normal. Abnormal gaze holding. Did she have nystagmus on eccentric gaze? Were the saccades overshooting? Were the saccades slow? Or were the saccades undershooting? So this is pretty easy. The answer is D, slow saccades. All right, now what causes slow saccades? When everything else is okay, the range of motion is full. Does this mean the burst neurons are affected, or are the tonic neurons in the medulla that hold positions of gaze, or are the abducens neurons bad, or is the cajal bad? Well, the answer is, where does the speed component come for saccades? This has to be a burst neuron disease. And you all should know what this patient has because it was first described in your country. This is the key anatomy: horizontal burst neurons, vertical burst neurons. Her predominant abnormality was in the horizontal system. And this is, of course, Wadia-Swamy syndrome, first described by Nosher, Wadia, and Swamy. You can see the small pons. The pons is actually almost smaller than the midbrain, just the opposite from what we see in progressive supranuclear palsy. And the cerebellum is also somewhat atrophied. So this is a spinal cerebellar ataxia type 2, one of the triplet repeat dominantly inherited cerebellar ataxias. All right, a little more anatomy. Let's see. These are the main structures in the midbrain that are related to vertical gaze. We have cajal. I told you this. It generates the position command for holding positions of gaze, and also the vestibular system, VOR. We have the rostral interstitial nucleus of the MLF. It's important for generating the velocity command, the pulse for saccades, vertical and torsional saccades. And we haven't talked about it yet, but the posterior commissure, you all know that, can sometimes lesions there lead to Paranose syndrome. Here, lesions cause up worse than down gaze palsy. So these are the three key structures for vertical gaze in the midbrain: cajal, RAMLF, and the posterior commissure. Let's see a case. Young man with a sudden onset of headache and confusion and a history of migraine. Can't look down very well. Good horizontally. Watch his doll's head, his vestibular response. Excuse me. Still making saccades, still making saccades. But with the doll's head, he brings his eyes all the way down easily. All right, what do we see here? Can you hear me now? Can you hear me now? I hope.
Yes, yes.
Okay, sorry. We were asking ourselves what this last patient showed. Was there a complete vertical gaze palsy, impaired saccades for down, impaired saccades equally for up and down, impaired vertical VOR? And the answer quite clearly was down gaze, predominantly down gaze palsy for saccades. I think we're hung up a bit here. Okay, which structure is most likely to be affected? Remember, he could, most trouble looking down with saccades. Was it ink, posterior commissure, or IMLF? Well, trouble was mostly down, so it wasn't posterior commissure. He could hold gaze, so it wasn't ink. He had trouble generating the saccades, especially down, so the lesion has to be in the RAMLF. Here's the lesion, right in the rostral midbrain and the caudal thalamus. What's the vascular territory? You stroke neurologists should know this. The artery of Pescherone, subthalamic perforator from the posterior cerebral artery. Here it is, coming off usually one side, but supplying both sides of the midline. What syndrome is this? What's the name of this syndrome? A man comes in with a vertical gaze problem, some confusion, sudden onset. It's the top of the Basler syndrome. It's usually due to infarction, ischemia in the distribution of the this branch of the posterior cerebral artery that we were talking about. One perforator that perfuses both sides of the midbrain. Characteristic butterfly lesion on the MRI scan. Importantly, the usual cause is an embolus, either artery to artery from or through the heart. You must look hard for emboli in these patients. This patient, we did not discover a cause, but he fortunately recovered. So let's just go through the clinical anatomical correlation here because it is precise. There was a defect of voluntary vertical saccades, especially downwards. They were slow. That's a midbrain lesion. That's in the RAMLF. Vertical head rotation caused the eyes to deviate fully upward and downward. He could maintain eccentric gaze. That meant the posterior commissure was intact. The interstitial nucleus of Cajal was intact. The cognitively waxing and waning, poor attention, probably relates to caudal thalamus. So this is a archetypical classical localization problem in neurology. And we have had cases where the diagnosis was missed because no one looked at vertical saccades, something which takes about 30 seconds. And then once you see that vertical saccade abnormality, you know you have a structural lesion in the midbrain. And if it's acute, you're going to worry about the embolus to the top of the basilar artery affecting the midbrain. Well, let's take a break. Tea time. I'll have a cup of coffee and maybe I can take a few questions now. It's probably best if I see them written so I can understand them. Should I stop the share now?
Maybe, yeah, you can stop the share. I'll just ask you the questions. Dr. Anup Giri asks you, what does the MVN do? Medial vestibular nucleus, what does it do?
Okay, can you hear me okay?
Yes.
Yeah, so MVN, which we are going to talk about in the second half of the talk, with a classical neurological lesion that affects it. It's the medial vestibular nucleus. It does two important things. It gets a direct input from the labyrinth, so it is the pathway of the horizontal vestibular ocular reflex. From MVN, it goes to the abducens nucleus and up the MLF, just like all the other conjugate pathways. And very importantly, it's also part of the gaze holding areas for horizontal movements. A lesion in MVN and the adjacent nucleus prepositus, hypoglossi, is going to give you a horizontal gaze-evoked nystagmus and often a horizontal vestibular VOR gaze palsy.
Okay, Dr. Meenakshi Sundaram, who was going to chair our session, but unfortunately had to rush to the hospital for an emergency. He asks you, what are the eye signs in Wernicke's encephalopathy?
Well, I'm not going to tell you because that's in the second part of the presentation, and I'm going to make you look at the case and tell me.
Okay. Dr. Srinivas, we are being bombarded by the Meenakshi Sundarams. Dr. Srinivas Meenakshi Sundaram asks you, What is the role of connections to the superior colliculus?
Oh, very good question. I mean, they're all good questions, but we don't think of the superior colliculus that much in clinical neurology because we rarely get isolated lesions there. It is the conduit, the way station, the circuit where commands from the cortex get to the brainstem. So whether I want to make a voluntary saccade, for example, that's mediated by my frontal lobe, or a reflexive sudden saccade that's mediated by my parietal lobe, the main pathway, the main direct pathway to innervate the pontine paramedian reticular formation and the RIMLF to get the burst nodes going is through the colliculus. The colliculus, you know, is actually part of the reticular formation. That's its structure. So just to repeat, cerebral hemisphere, either frontal or parietal, voluntary or reflexive, to the colliculus, and then on to the brainstem.
Thank you. Doctor, I don't know who's asking, but he's asking, what are the eye movement abnormalities seen in hydrocephalus and what is the mechanism?
I'm sorry, in what condition? In what condition?
Hydrocephalus.
Hydrocephalus. So a couple of presentations. In acute hydrocephalus, we get expansion of the posterior part of the third ventricle, the recesses, and they compress the colliculus and the dorsal midbrain. So what do we see? Remember, posterior commissure mostly or affects upward gaze more than down gaze. So we get a Perronneau syndrome, a failure of upgaze, a limitation of upgaze, or a slowing of upgaze as an early sign of hydrocephalus. What else might we get? Well, eventually we can get compression, ischemia, probably secondarily to other parts of the midbrain, and that would include pupil reflexes, especially a light near dissociation, which can occur because of the segregation of the pupil fibers for accommodation and for pupil dilatation. But also we can get the whole picture of a Perronneau syndrome. And Perronneau, you know, the first great neuro-ophthalmologist, only described upgaze problems. He was Charcot's ophthalmologist. But then we have the Kerber-Salis-Elschnig syndrome, including retractory nystagmus, convergence nystagmus, lid retraction, and sometimes we get a peculiar form of ocular bobbing, pretectal bobbing, and on and on. Mechanism, usually compression of the midbrain.
When severe, instead of just impairment of upgaze, does it cause a little downgaze at rest and so-called sunset sign?
Okay, a sunset sign is what we often see in children, infants, and it's kind of a lid retraction and the eyes are down. This can be normal in many infants. The way we usually show that it's normal is we do a doll's head vertically and the eyes will go up. The eyes will go up. So when you can overcome this in an infant with the sunset sign, then it's probably going to be benign. You can be a little bit less worried and follow the patient rather closely. Lid retraction for sure in adults can occur with Perronneau syndrome, or we call it the dorsal midbrain syndrome, is probably a better explanation, a better name for that. And yeah, so bottom line there, you can get lid retraction.
Dr. Vishal Pawar, he's a neuro-otologist and neurologist in Dubai. He used to be in Pune. Now he's asking you, where is the pathway for fixation suppression of vestibular nystagmus?
Okay, where is the pattern for fixation suppression of vestibular nystagmus? The usual rule and the most common way and the simplest way to think about it is it is a use of the pursuit system to direct, to generate a command opposite to the vestibular signal. So we can also consider suppression of vestibular nystagmus as a special case of pursuit used to track a target that's moving very slowly or not at all. So the pathway then is the same pathway as pursuit. The cerebellum is very important, a part of this, the flocculus and the cerebellar tonsil. We see problems in ICA syndrome for this. So it is a pursuit pathway. The pursuit pathway is basically comes from the cerebral cortex down to the midbrain, and then down to the pons, back out to the cerebellum. It's a long, complicated pathway. One general rule you can remember that's very helpful is when you have a cerebral hemisphere lesion, you have trouble with generating contralateral saccades, and you have trouble generating ipsilateral pursuit. Contralateral saccade disturbance, ipsilateral pursuit disturbance. We often can bring that out with an OKN tape.
Okay. Dr. Kamar Green asks a complicated question, I think about OTC. He's asking you, what's the difference between head position and ocular counter role in INC versus RI-MLF lesions?
Well, since I know who this guy is and he's working at Hopkins, I'm going to tell him about this tomorrow. That's just too complicated.
Okay.
I'm going to, if we have, you know, at the end of my talk today, I'm going to talk about the ocular tilt reaction, and that issue will come up then.
Okay. Dr. Vrishab Gavali asks you, where do involuntary saccades originate?
So, involuntary saccades. The best way to think about that is the most involuntary saccade is the quick phase of vestibular nystagmus, and that basically originates in the brainstem. Not much cerebral influence on that. But if we're going to go above and we're going to think about, well, I'm sitting here and suddenly someone brings me a cup of coffee and I glance over there, that's an involuntary saccade. I'm not thinking about it. The pathway basically is from the occipital lobe, you know, after visual inputs get to the occipital lobe, and then to parietal cortex, the parietal eye fields, PEF. In contrast, voluntary saccades, for example, I'm going to look all around at this picture and try and find something in it. That comes from the FEF, frontal eye fields. So you have this dichotomy, parallel pathways, voluntary frontal, involuntary reflexive parietal, voluntary self-generated frontal, involuntary reflexly driven parietal. They both go to the superior colliculus, and in turn, they go to the brainstem, midbrain, pons, and generate the saccade.
Dr. Rohit Wadikhe asks you, why is there only upward gaze palsy in superior colliculus lesions like Parinot syndrome? Why do you have only upward gaze palsy in Parinot syndrome in superior, though the superior colliculus is affected?
Well, okay, so I think what we know is that a pure superior colliculus lesion does not create a specific Parinot syndrome or specific upgaze palsy. It creates an isolated saccade disturbance, and depending upon if it's the whole colliculus or one colliculus or the other colliculus, it'll be contralateral to the side of the lesion. The problem has been that almost all the lesions, excuse me, that affect the superior colliculus also affect the underlying midbrain. So you're almost always getting not the effect just of a colliculus lesion, but the effect of a midbrain lesion, a pretectal lesion, a true Parinot syndrome. We do have a few cases of isolated superior colliculus lesions. They show at least rather subtle changes in reflexive saccades and anti-saccades. And finally, the other important point is that if you have a monkey and take out the colliculus, for the first day or so, it will have considerable difficulty generating a saccade to that whatever part of that colliculus was involved in generating saccades to a certain place. But within a few days, there is another parallel pathway coming from the frontal eye fields directly to the brainstem that can help take over. So it's the old rule. Unless we see a patient within seconds or minutes of an acute lesion, we're never seeing just the effect of a lesion. We're also seeing the effect of the brain trying to compensate for that lesion, to enlist other pathways, to modify behavior. So that's the problem. If you would have a patient with an acute superior colliculus lesion, I would bet that patient, and it was a complete lesion of both sides, I would bet the patient would have a lot of difficulty generating any saccades, but could develop and generate pursuit and vestibular movements.
We have one question. Why do you get vertical diplopia in lateral medullary syndrome?
Well, it's usually, and I'm going to talk about this too in a couple of places because it's so important in the second half of this talk, it's usually due to an otolith ocular imbalance. It's part of the ocular tilt reaction. We think of spontaneous nystagmus as coming from a vestibular imbalance that affects canal inputs, but when otolith inputs are affected, we also have problems in maintaining eye alignment, and it's usually a vertical skew deviation. And I'm going to go over that later today if we get to it.
Okay, we have a couple of questions more. Before you start, you tell me when. Dr. Ankur Apte is asking you, can eye movement abnormalities occur in NPH?
NPH?
Normal pressure hydrocephalus.
I'm sorry, you mean normal pressure hydrocephalus? Hello?
Yes. In normal pressure hydrocephalus, do you get eye movements abnormalities?
So anecdotally, I can tell you what I have found. The patients, I have two patients with this, they had a marked difficulty in generating rapid saccades back and forth. Now, in Parkinson's disease, maybe Asif Sheikh will talk about this, one of the main findings with saccades early on is they can make a nice saccade, a nice reflexive saccade, if a target suddenly appears. So if you ask them, okay, look at my finger, they do it pretty good. But if you ask the patient with Parkinson's disease to look back and forth as fast as they can between two stationary targets, your fingers apart, the saccades, rather than a single saccade, they generate multiple small saccades, and they often stop for a period of time between each saccade. This was described 50 years ago beautifully by De Jong and Melville Jones in Canada. What I've seen in NPH is the same problem, but vertically. I ask those patients to look up and down as fast as they can. They get stuck. And I have one patient who was treated with NPH. The gait got much better and his eye movements got better. So I'm throwing this out to you. If any of you have the opportunity to video a patient with NPH before and after surgery or shunting, please check vertical saccades. Ask them to look up and down as fast as they can between two targets. Fast. Keep looking up and down, up and down. So okay. I don't know if you can see me, but two targets up and down as fast as you can.
Okay. Yes. What are the eye movement abnormalities in the Guillain-Molleret triangle lesion?
In Guillain-Molleret triangle?
Yes.
Oh my gosh. So I hope you plan to stay about 6 hours with me today. We're going to cover every eye movement abnormality there is. Bottom line, and if you want me to come back and talk one day about nystagmus, I'm happy to do that. The bottom line is they get the syndrome of ocular palatal tremor. And the eye movement abnormality is a pendular nystagmus. The short story is, if you see a patient with pendular nystagmus, not jerk nystagmus, number one, you always look at any patient with pendular nystagmus, you look in the mouth and you look and see if the palate is moving. Any patient with pendular nystagmus, they're usually going to have a demyelinating disease or ocular palatal tremor. So the main finding is this, what we call, used to be called ocular myoclonus. It's really a pendular nystagmus. All the other signs that they have, these patients usually depend upon where the lesion is. They could have a hemorrhage in the pons, a hemorrhage in the cerebellum, a hemorrhage in the midbrain, and they're going to have those other signs. But if you deafferent the olive, you get this syndrome of ocular palatal tremor. We can talk about that in more detail on another day. Well, should we move on?
Yes, I think so. We have more questions, but maybe we'll take it later. You can start the remaining part of your presentation.
Okay, so I will share my screen. And we'll go back to wherever I was. Okay, I hope everybody had some tea. I assume you can hear me okay? Yeah.
Yes.
All right, here we go.
It's not tea time here, so I don't know what they are having, but anyway.
Okay, so part two. Now you're going to have to think. Cerebellum, you know, it's a wonderful structure. There are more neurons in the cerebellum than there are in any other part of the brain. I'm going to make it easy for you today, so hang in there. So there's a great history, of course, of the cerebellum, and so many of the famous names in neuroanatomy and physiology made their careers on the cerebellum. Cajal, Purkinje, and why is cerebellar localization so difficult? Well, I'm going to tell you the reasons, and then we'll try and make sense out of it. There is an extensive and complex afferent and efferent connectivity of the cerebellum with the brainstem, the thalamus, and even beyond to the cerebral hemispheres. You know, there's a whole cognitive syndrome now associated with cerebellar disease. The cerebellum is connected with virtually every part of the motor system of the brain. It's vital. One reason is it has a fundamental role in maintaining accurate motor performance, in showing a robust adaptive capability. I mentioned this earlier. You know, the cerebellum gets involved right away when there's a lesion trying to fix things up. And of course, if the cerebellum itself is sick, you can't fix things up. And this is why patients with lesions in the deep nuclei of the cerebellum are often very permanently impaired. The deep nuclei are, if they're affected, it's very hard for the cerebellum to fix things up. The cerebellum does better when the vermis is affected because other parts of the vermis can take over. Anyway, another point is we all have natural, exposure to trauma, diseases. Our brains have been fixing up things all our lives as we've grown, and the eyeball takes different shapes. These are a little different from one person to another. So if you have a cerebellar lesion, your history, the history of which the cerebellum has been fixing you up, is going to be revealed in different ways between different people. So you can have different cerebellar eye signs with the same lesion in different people because it has had to deal with prior problems. So more than one area in the cerebellum may participate in one function and may substitute for another and hide a defect. Of course, that's both good for the person who's affected, bad for the diagnostician. And then the three major cerebellar arteries, and this is where we get into stroke syndromes, ICA, PICA, and SCA. They each perfuse part of both the cerebellum and the brainstem, and even with ICA, the labyrinth as well. What does this mean? Analyzing deficits in patients with strokes is complicated by uncertainty over whether the lesion is just in the cerebellum or also involving the brainstem or labyrinth. So these are some of the complications in interpreting cerebellar eye signs and other cerebellar disorders. And it's a reason why for 40, 50 years, we never really could decide until we made some very focal structural lesions in monkeys, for example, what was truly a cerebellar eye sign. Okay, 3 basic functional anatomical cerebellar syndromes. Sorry. We have the syndrome of the vermis and the posterior fastigial nucleus. That's called the FOR, fastigial ocular motor region. That's one set of cerebellar problems. There's the vermis, there's the projection to the deep nucleus, and that mostly deals with issues of saccade accuracy. Saccade accuracy, dorsal vermis, posterior fastigial nucleus. Then we have the syndrome of the nodulus and ventral uvula. These are parts of the old vestibular cerebellum. We're not going to talk about that too much today, but these people have problems with slowly changing vestibular responses. We see things like positional nystagmus, central positional nystagmus. We see periodic alternating nystagmus, PAN, with lesions here. And then we have the syndrome of the flocculus and paraflocculus. And remember, in humans, we call the paraflocculus the tonsil. The tonsil. There they are. So these structures, flocculus and paraflocculus, this is where a lot of clinical signs appear if these areas are malfunctioning: gaze holding, pursuit, and really fast, high frequency vestibular movements, the so-called head impulse. Now I'm going to concentrate on saccades today because they're so easy to examine at the bedside, and the clinical anatomical correlations are so precise. So vermis, fastigial nucleus, or the fastigial ocular motor region, and the fastigial nucleus projects to the particular formation, PPRF for horizontal and the RIMLF for vertical. So remember a few key points. The dorsal vermis contains Purkinje cells. They inhibit their target neurons in the posterior fastigial nucleus, called FOR. Each FOR projection crosses immediately and then runs astride the contralateral superior cerebellar peduncle. We'll see pictures in a second. So each FOR normally acts to stop ipsilateral saccades by stimulating inhibitory burst neurons. So I'm going to take you through a little anatomy and some ocular motor disorders when there are lesions in these areas. But this is the key. If you remember anything, you can remember 3 points. Vermis inhibits FOR. FOR projection crosses immediately and runs astride the contralateral superior cerebellar peduncle, and each FOR stops ipsilateral saccades. Do not panic when you see the next slides. Just be calm, meditate, follow along. There is some clinical light at the end of the anatomical tunnel. Take a deep breath. So this is from my colleague, Dan Gold, and one of his fellows, Wu Choi. This little diagram. If you don't have to memorize all the details here, but there are going to be a few take-home points, which I think will help you out clinically. Excuse me. I need a little coffee. Remember, Purkinje cells inhibit the deep nuclei. There they are in the dorsal vermis. Fastigial nucleus axons immediately cross and project to contralateral brainstem where they drive burst neurons. There's the fastigial nucleus. It crosses it immediately and goes through the other fastigial nucleus. For those of you who are brainstem anatomist, you remember this is the same issue in the ocular motor nucleus, the third nerve nucleus. That's why an ocular motor nucleus lesion gives you a upgaze palsy, because the superior rectus fibers cross through that. There's the vestigial projections going down to the brainstem. And again, it's the activity inhibitory burst neurons, which is most important. So it would work to facilitate contralateral saccades and inhibit ipsilateral saccades. Now, FOR. What can a unilateral lesion cause? It causes ipsi versus overshooting and contra versus undershooting. It's because the inhibitory burst neurons no longer inhibit ipsi versus saccades. A unilateral structural lesion is not possible because of the immediate crossing of the FOR. We only know what a unilateral lesion does by virtue of neurotoxins in the FOR experimentally, or if you affect the vermis on one side, and we'll get to that. So, bilateral lesions cause hypermetric saccades. There's our vestigial nucleus affecting both sides. Now, what about the vermis? It inhibits the vestigial nucleus on one side. Lesions of the vermis have the opposite effect. Ipsiversive undershooting and contraversive overshooting as the vestigial nucleus lesions. Bilateral lesions of the vermis cause hypometric saccades. Let's see a case. Oops. All right, what does this patient show? Well, I didn't show you his pursuit, but I'm going to tell you it's normal. Could he hold eccentric gaze? Yeah, there was no gaze evoked nystagmus. Did he have overshooting saccades? Well, you can tell me. Were the saccades slow? No. Were there undershooting saccades? Well, clearly this man had saccade hypermetria in both directions. Here's a little diagram to show you what he was doing. He was overshooting, and sometimes he would actually oscillate back and forth about the target. Here it is again. He oscillates about the target. These are macrosaccadic oscillations. Big saccades going back and forth about the target because he couldn't make a small enough saccade to get to the target. He had to keep going back and forth about it. Here's the lesion. Smack in the vestigial nucleus region. There's our pons, our cerebellum, the fourth ventricle. Where the two arrows are is where the vestigial nucleus is missing. Now here's another patient with a degenerative disease. And just to show you that you can treat these oscillations sometimes. He had trouble with reading, and then we treated it with memantine. Here's his recordings. There, again, the same kind of a thing, overshooting and oscillating back and forth. This was particularly bothersome to him during reading. Most patients don't complain too much of this unless they do something like that. Here's some recordings of his position of his eyes. Before the memantine, you see the red traces. He's jumping all around, back and forth. After the memantine, much less. So this gave him symptomatic improvement. All right, what do you see here? So are these normal saccades? Are they too big, too small? Are they slow or are fast? Is he having trouble holding gaze? Are they promptly generated? So pursuit was normal, gaze holding was normal. The saccades, you might think they were slow, but in fact, he had a number of hypometric normal speed saccades. Here was his lesion. It was involving the dorsal vermis, what you would predict. He had a hemangiopericytoma, and it was removed, and he was considerably improved. Let me try and show you his video one more time. Excuse me. And you should look carefully, and I think you'll appreciate that there are a lot of little saccades, one after another. Bump, 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 bump. So it wasn't a single slow saccade. This is an extreme example of what happens to a vermis with a vermis lesion. A whole series, 4 or 5 small hypometric saccades. All right, let's review this saccade business. Why are saccades hypermetric with vestigial nucleus lesions and hypometric with dorsal vermis lesions? Again, the vestigial nucleus acts to stop ipsilateral saccades. With bilateral vestigial nucleus lesion, they're hypometric. With bilateral vermis lesions, they're hypometric. So the effects of a lesion in the vermis are opposite to those in the deep nuclei. Okay, so just a little more about the cerebellum. I mentioned to you the flocculus and paraflocculus being important for pursuit and gaze holding and some other things. So let's just see a case. Patient with a cerebellar degeneration. There's some gaze evoked nystagmus with a little downbeat component. The gaze nystagmus gets less, and when she comes back to straight ahead, there's a rebound nystagmus. Slow phases were in the direction she was looking. When we go in the other direction, you'll see a little more clearly the downbeat component. Downbeat is often brought out on eccentric gaze or with convergence in these patients or with positional head positions, supine, and there's another rebound nystagmus. So gaze evoked, downbeat, rebound nystagmus. Now we're going to ask her to suppress her vestibular ocular reflex. She's going to fixate a target moving with her head. You see that on the left. On the right, she's going to be asked to make smooth pursuit following a target moving in front of her. So that's smooth pursuit. It's choppy. It's very choppy in both directions. You can see that. The mistake we often make at the bedside is we go too fast. And then now we're going to see suppression of the reflex. She's fixating a target, rotating with her head. She can't suppress it. The eye's jumping around because the vestibular reflex is still working. Failure of fixation, suppression of vestibular nystagmus due to a pursuit deficit related to cerebellar disease. Classical signs of many of these degenerative cerebellar problems. Okay, how about a patient who presents with the acute onset of imbalance, hiccups, numbness on one side of the face and opposite side of the body? I don't need to tell you how to diagnose this one. This is probably the most reliable, consistent vascular ischemic syndrome of the brainstem. Let's see the eye movements. Closes the eyes. Look what happens when he opens up. They were deviated to one side, and he had to make a bunch of little saccades back to center. So this is, now when making saccades, he's overshooting in one direction, undershooting in the other. Undershoot, overshoot. A few little saccades to the right and a big one to the left, followed by some small corrections to the right. Undershoot, overshoot, undershoot, overshoot. All I need to see is that, and I can usually diagnose the patient. Going up, same thing, goes off to the side, to the left. Trying to make a vertical saccade, you see the little corrections to the right. Same when he comes down, maybe not quite so obvious. There are the little corrections. So this is called lateral pulsion of saccades. Pupils are dilated by drops. So no matter what direction of saccade, tended to veer off to the left. Lateral pulsion of saccades. There's the lesion. I think you can all see that on the MRI. It's in the dorsal lateral medulla. This is Wallenberg syndrome. It's a pica distribution infarct involving the dorsal lateral medulla. We'll come back to that. It's fascinating. It causes a functional lesion of the cerebellum. It interrupts afferent inputs from the brainstem to the cerebellum, specifically from the inferior olive to the dorsal vermis. And when you lose the dorsal vermis when the dorsal vermis activity is changed, it actually becomes over-inhibitory on the fascicular nucleus. You get a unilateral fascicular nucleus lesion with overshooting to the side of the lesion. Let's see. All right, now I want you all to get this one. This is the most important case of the day, that you remember this syndrome and never miss it. Okay, so a young woman pregnant with a few weeks of nausea and vomiting. What did we see? Pursuit was not shown there, is actually somewhat impaired. The clear finding was abnormal gaze holding. Saccades were fast. They got her on target. She just couldn't hold gaze. So where is the abnormality in the brainstem when horizontal gaze holding is defective? We talked about this earlier. Not burst neurons. Saccades were good. Again, medial vestibular nucleus, nucleus prepositus in the medulla. That is the horizontal gaze holding area. It couldn't be the abducens neurons. She had a full range. And vertical was okay. We didn't show that. So this is the key anatomy. Gaze holding networks for horizontal movements to generate the position command. MVN, medial vestibular nucleus and nucleus prepositus. What's the diagnosis? I know you can all get this one. This Wernicke's disease. Here's the lesions. Smack in the floor of the fourth ventricle, right where the area postrema is, right where the medial vestibular nucleus is, and next door, the nucleus prepositus. You can see it on the right-hand image. Those two little bright circles are smack in the medial vestibular nucleus. So think of the causes of this syndrome. This gal had hyperemesis gravidarum. Now, Wernicke's syndrome can show ophthalmoplegia, nystagmus of virtually any type, often a vertical as well as horizontal, gaze palsies, intranuclear ophthalmoplegia. It's an absolute emergency. We see it in a lot of circumstances now where there's malnutrition, alcoholism, eating disorders, bizarre diets. I had a young girl who went on a 3-month ice cream diet, and then she ran a little 10K race and developed a rather tragic acute Wernicke's disease that was not recognized. Excess vomiting, like we saw in our pregnant patient. Chemotherapy now. In infants, B1 deficient formula. And with the obesity epidemic in our country, we see it after post-gastric diversion procedures. Living alone, isolation, old people without anybody supporting them, social isolation. And finally, you may all know, you can precipitate an acute attack of Wernicke's with a glucose load. It will take up all the remainder of your stores. Treat emergently, immediately with intravenous 500 milligrams of B1. Watch out if they don't respond, make sure that their magnesium is not also deficient. You need magnesium. It's another important cofactor for the enzymes in which B1 is involved. Well, I think we'll finish up with a little bit about skew deviation, if that's okay. This is the famous dog of Thomas Brandt, Tessa, a golden retriever from Munich, who had a ocular tilt reaction. And this was a little picture I took when I happened to be in Chile. They're everywhere if you look for these ocular tilt reaction. And they cause vertical double vision, as someone asked about earlier. And it's a frequent sign of otolith ocular imbalance from brainstem lesions. Rarely from peripheral lesions, or if it's peripheral, it's mild and rapidly compensated. When you see an ocular tilt reaction, vertical diplopia from a brainstem lesion, it's usually going to be, if it's not a muscle palsy, an otolith ocular disturbance. Comparable to nystagmus canals, and diplopia otoliths. So, ocular counterroll or torsion is the response to a static head tilt. It's called the otolith ocular reflex. When we tilt our head, the eyes counterroll. It's vestigial in humans, so they don't counterroll as much as the head rolls, but they do counterroll and produce some torsion. And it's only about 10% normally of the head tilt, but it plays a major role in pathology, which is brought out by brainstem lesions, and we get what's called, excuse me, the ocular tilt reaction with skew deviation. What is a skew? It's a vertical ocular misalignment not due to an ocular muscle weakness. And the usual differential is from a fourth nerve palsy. You know how to diagnose a fourth nerve palsy, Belchowski test. It gets much worse when you're looking at the testing in the direction of action of the superior oblique. That'll be for another day. But this is the issue of ocular tilt reactions. Now remember, in we frontal-eyed humans, as I said, the normal response is a lateral head tilt. To a lateral head tilt is pure counterroll, torsion without skew. So our perception of vertical upright is maintained. We tilt our head, the eyes rotate a little bit, but we still know which way is upright. In pathology, when there's a stroke, for example, or a brainstem lesion, the abnormal response to a perceived shift of the vertical becomes a compensatory head tilt. Of course, it's not really compensatory because there's no real peripheral problem, an ocular counterroll, and a skew deviation of the eyes that produces vertical double vision. So because the perception of vertical is tilted, we develop this compensatory response, which has these pathological features. Now, this was nicely described by Michael Hamagi in 1979 in a patient. And again, this is an acute tone imbalance of a static utricular writing reflex, analogous to spontaneous nystagmus from a canal disturbance. Here's our patient. There's a head tilt. There's a skew. You can see one eye is higher than the other. And if you look at the back of the eye, you see counterroll, torsion. So my friend Paul from Taiwan sent me this nice picture so I can remember that we become rabbits. when we developed a pathological ocular tilt reaction. Rabbits are lateral-eyed, okay? So when a rabbit tilts its head, one eye goes up and the other eye goes down. Just take a look at this one more time. You can see one eye goes up and the other eye goes down. That's normal for a rabbit. That's physiologic. That's the rabbit trying to keep his eyes aligned along the horizontal meridian to optimize his view of the world. Doesn't help much when one eye's to the sky and the other eye's to the ground if there's a predator out there. He wants his eyes aligned as best possible, each eye horizontally. So a rabbit does this. A rabbit develops a skew physiologically. That's normal. It's protective. It's functional. This old reflex, this phylogenetically old ocular righting response to lateral tilt, comes out in we humans when there's an imbalance. So instead of the eyes just counter-rolling, they skew, and we get a skew deviation. You can measure this in various ways. You can use the bucket test. So you're measuring perceptually the patient's sense of upright. You have a little line inside a bucket, and you put the patient's head in there, and then you have on the outside a protractor with a plumb line, so you can measure the tilt. And the patient tells you when they see the line is vertical, and then you can measure how far off they are. That was first nicely shown by Lars Friesen in 2000, and then our colleagues in Munich put this on the map for all of us. A simple bedside test. If you're worried about an ocular muscle palsy, you can do one eye at a time. Because remember, with superior oblique palsy, the higher eye is turned out with the ocular tilt reaction. The higher eye is turned in. Superior oblique palsy turned out, ocular tilt reaction, higher eye turned in. All right, here's the pathway. It's kind of it's not complicated. It's simple. You have fibers coming from the utricle, going to the vestibular nucleus, and then up the contralateral MLF. Let's look at a patient. May you remember her? Simple alternate cover test. Eye goes up, the other eye goes down. Watch the lid. That's often the best way to see this. And you can see she has a head tilt, and the head is tilted to the right ear, and that right eye is lower. Okay. She had a left hyperdeviation and a right head tilt. The alternate cover test, you watch the eyes bouncing back and forth. When it comes down, when you remove the cover, that means it was up, it was higher. Very simple. Here's the lesion. You may remember, same patient I showed you earlier. This was an I&O. And here's her lesion in the MLF, and it's after the otolith ocular pathway has crossed, after they crossed. Look at this patient. You saw him before too. His head's tilted the other way. Look at his cover test, down, up, down, up. So the right eye is higher, the left eye is lower. So you may remember this was Wallenberg syndrome, the same patient. There's the lesion in the dorsal lateral medulla. It's actually involving the vestibular nuclei caudally, the otolith projections and the caudal vestibular nuclei. He has a skew because of involvement of the caudal vestibular nuclei, to which project mostly otolith inputs. So here's the rules. We have skew deviations before or after crossing of the otolith ocular pathway. They can be up in Cajal or the MLF on one side, or the vestibular nucleus, or even the periphery, but remember they're small and transient. The eye is always higher on the lesion side, eye high. Eye is lower on the lesion side when it's low. So the low lesions, medulla, eye lower on the side of the lesion. The high lesions, pons and midbrain, eye higher on the side of the lesion. Eye high, eye low, low, something like that. So that's it for today. I'm running out of gas. Just a reminder, remember the physiology and anatomy for eye movement control. Know these clinical, archetypical, classical clinical examinations we saw today. We saw INO, we saw horizontal gaze palsy, we saw an isolated PPRF lesion, Waddy-Swami. We saw vertical gaze palsy. We saw cerebellar lesions, vermis, fasciculus nucleus, and the flocculus. We saw downbeat, gaze evoked, and rebound nystagmus. We saw Wallenberg syndrome, lateral pulsion and skew, Wernicke's disease, any kind of nystagmus. Didn't talk about it today. They often lose their horizontal vestibular ocular reflex because their medial vestibular nucleus is involved. Always suspect and treat emergently. And we talked a little bit about skew deviations. Now I need some help on the last case. If you can help me with this localization, I'd appreciate it. Okay, thank you very much. I'll stop the share now.
I'm going to ask you the remaining questions. What you tell me when you run out of gas. Till then, we'll or you want to refill your coffee?
So I will take no more than 75 questions.
Okay. Somebody's asking.
I'll take a few.
Okay.
People can, may say one more thing. Yeah. If anybody's interested in a PDF of this, I'll send it to, or he probably has it, I'll send it to Sudhir here. You can ask him for it. And if you have any burning questions, send me an email.
The PDF will be available on the Fine app. So you send me the PDF and then we will put it in the Fine app. So everybody who has the app will get the PDF. They don't have to email me. Okay, now somebody is asking, is ocular bobbing and dipping seen only in comatose patients?
Ocular bobbing. There are 4 types of ocular bobbing. You should remember one in particular, the classical ocular bobbing. It was first really described well by C. Miller Fisher. And what that is, it's a downward saccade, spontaneous, and a slow drift back up. So, and it occurs every 5 seconds or 10 seconds. In the classical case, it's due to a horizontal gaze palsy, due to usually a pontine lesion, usually a pontine hemorrhage, sometimes a pontine infarct, and it's associated almost always with a complete horizontal gaze palsy, and the patient can be comatose or with a markedly a decreased state of consciousness. C. Miller Fisher thought these were just somehow spontaneous vertical saccades and with impaired gaze holding. That may or may not be exactly right, but it's very distinctive. There are lots of variations on this: reverse bobbing, inverse bobbing, converse bobbing, ocular dipping, and some are a slow phase problem, like a nystagmus, and some are a quick phase nystagmus problem. These other forms can occur in metabolic disturbances as well as structural lesions, not specific. But remember, classical ocular bobbing is almost always due to a pontine structural lesion.
Okay, somebody is asking you, please elaborate the reason for the round the house sign in PSP? And then they are asking another one, Dr. Bhavin asks, which movement in PSP goes first, up gaze or down gaze, and why? Does the prognosis change accordingly?
You know, people are giving me a quiz rather than me giving you a quiz.
We are actually going
That,
to have
that's
Asif.
okay.
Asif is going to talk about eye movements in movement disorders in a day or two. Maybe
Yeah.
that.
Well, let's talk about PSP just for a second, because it's one of my little hobbies. Um, Either up or down gaze palsy can go first. Usually it's down gaze, and my recommendation is the earliest sign of PSP is probably going to be slowing of downward saccades, which you can bring out nicely with an OKN tape or with asking the patient to look up and down rapidly. Sometimes up gaze appears to be a little more affected than down gaze. Of course, there are a number of other signs with PSP, especially saccadic intrusions, square wave jerks, very common. And this round the house sign probably reflects the brain's attempt to kind of get a horizontal saccade going and hope for a little vertical component. I think Asif Sheikh will talk about that a little more. But remember, if you suspect PSP, do two things. Look carefully at the midbrain MRI for flattening and shrinking of the midbrain, emperor penguin sign, so-called, and look for vertical saccade slowing, maybe the most subtle sign.
Okay, I'm taking, there are too many questions, but I'm taking some of them now. Dr. Ashish asks, what's the minimum or what is the optimum distance to be kept for examination of saccades? Do you do finger and nose or two fingers on each side? How do you examine?
Yeah, well, I think either one is okay. What are the mistakes? We sometimes see a little hypometria with very big saccades, which can be normal. We sometimes see a little overshoot when they make a saccade back to center. That can be normal. We especially see a little overshoot from up to straight ahead when for downward saccades. So what I like to do is two things. I first keep my fingers maybe only 15 degrees apart, so that's sort of halfway. And I ask them to make saccades between my finger and my nose, my finger, about 15 degrees. Normally, people should make an accurate saccade, maybe a little bit of undershoot. Yeah. So that's the first thing I do. The second thing I do is I put my two fingers apart, about 15 on either side, and ask them to make saccades back and forth. That's where I look for slowing. That's where I look for slowing. Remember, if you can see the eye moving, if you can actually follow with your eyes the patient's eye's trajectory, it's going to be slow. Usually when saccades are normal speed, you can't really see the eye moving from one place to another. But if you can follow the eye moving, that's probably a sign that it's a slow saccade. Slow saccades can be with certain medicines, with inattention, etc. But like all of neurological signs, you put them in the context in which they are.
Okay, two questions related to skew. Dr. Tharak Bemuri asks you, what do you mean by skew being comitant or incomitant?
Okay, so when we talk about strabismus, we say a comitant strabismus means it doesn't change very much when you look left, right, up, or down. A good example of that would be, a child with strabismus. If it's horizontal, when they look left or right, it's the same. If you have a lateral rectus palsy, it's going to be much worse when they look in the direction of the paretic muscle. So the words comitant, non-comitant are sort of non-paralytic, paralytic. Now, in fourth nerve palsy, it usually is non-comitant. The deviation, vertical deviation, is worse when the affected eye is adducted and attempting to look down. That's the that's the place in the orbit where the superior oblique muscle has its main effect on looking down. Okay, skews tend to be comitant. There's usually there whether you look left, right, up, or down. These are not 100% hard rules. The second rule is, again, with a skew deviation, the higher eye is twisted in, the top pole rotates toward the nose. With a fourth nerve palsy, the higher eye is twisted out. Superior oblique is an intorter, it's not working. So the top pole is rotated the other direction. So if you can get an idea of what torsion is with the subjective visual vertical or fundus photography or whatever, then you will be able to distinguish between skew of an ocular tilt reaction and a superior oblique palsy.
Okay, there are more questions, but I think, like we said, you are going to come back and we are going to keep you busy. So you could take some more topics, and I think you are going to take the 3 Ws, Wernicke's, etc., whatever. So we are going to have more talks, and people will have opportunity to ask you more questions. Regarding the Fine app, this app will be available both for the iOS as well as for Android. Look for the FINE Forum for Indian Neurology Education app, and you will get the PDFs of all the talks that we are going to have. So we'll call it a day. I must thank Dr. David for taking out time for us in this difficult time and making it enjoyable for everybody and extremely informative as usual. The videos have worked pretty well. They are not as good as when you show them directly to us, but still they are excellent and we could make out everything. Thank you, David, and have a great day.
My pleasure, and stay healthy.
Thank you.
Okay, bye-bye.
Bye, everybody.